Side please. Starting with the history, in 1885, the Osler first published the comprehensive discussion of infective aneurysm. He termed this aneurysm as mycotic, but this created a very confusing. Everyone think it's a because of the fungal infection, but it is he coined the term because the aneurysm which he saw was resembling a mushroom. So now these days, this term is obsolete. We are using the term infective arterial aneurysm only, not mycotic aneurysm. In 1923, Stangen and Walford demonstrated the infective aneurysm result from a variety of blood-borne septic condition, not just endocarditis. Because Osler which, defined the aneurysm resulting from the infective endocarditis. And Somerville in 1959 reported a third type of arterial infection, one that occurred in pre-existing atherosclerotic aneurysms. Change. Slide. Now coming to the classification, infective arterial aneurysm are classified into 4 types based on etiology. First one is microbial arteritis with aneurysm formation due to non-cardiac origin, bacteremia or contagious spread of a localized infection. The second one is post-traumatic infective pseudoaneurysm, mostly found in a person with illicit drug abuse. And nowadays it is found also in because of the use of the endovascular closure devices. It's also because of that also. The third one is infection of a pre-existing atherosclerotic aneurysm from a bacteria or a contagious spread. The fourth one is infective aneurysm from a septic emboli. Now coming to the first one in detail, the microbial arteritis. The bacterial seeding can occur in a non-aneurysmal arteries with a pre-existing wall irregularity caused by atherosclerosis or congenital abnormalities. Example, aortic coarctation, patent ductal arteriosis. The aneurysm is a secular rather than a typical fusiform degenerative aneurysm. The old name arteries are at risk, but the aorta is the most commonly involved because the surface and the involvement in the atherosclerosis is more common in the aorta. The condition associated with microbial arteritis include diabetes, cirrhosis, chronic hemodialysis, post-trans, mostly because of the immunosuppression. The condition which all leads to the immunosuppression can lead to these like alcoholism, chronic glucocorticoid therapy, chemotherapy, and malignancy. Now, the second one is post-traumatic infective pseudoaneurysm. Arterial trauma leading to a direct bacterial inoculation of the arterial wall can result in an infective arterial aneurysm. Bacteria can be introduced at the time of endovascular access or during drug abuse. The use of percutaneous closure devices for endovascular procedure has been reported to be associated with infective pseudoaneurysm. Most common artery involves the femoral artery because it is the most common artery we use for the access. Then coming to the next one, the infection of a pre-existing aneurysm. Pre-existing aneurysm can be secondly infected by hematogenous or contagious spread. Aneurysms are susceptible to infection because of the disease intima and intraluminal thrombus permit bacterial seeding. Aneurysm associated with bacterial growth in the thrombus are more apt to rupture. The greater number of positive cultures are found in those patients with rupture aneurysm compared with asymptomatic and symptomatic aneurysms. And the last one is infective aneurysm due to endocarditis. The currently less than 10% of the infective arterial aneurysm originate as classically described by Osler. Septic cardiac emboli may lodge in the lumen of the vasa varorum. It leads to the ischemia of the vessel wall. Once the artery is infected, rapid focal and progressive deterioration occur, resulting in characteristic secular and multi-lobed mushroom-like aneurysm. This process often leads to a locally contained rupture and formation of false aneurysm. The infective aneurysm associated with cardiac emboli are frequently multifocal, involving the aorta, intracranial circulation, and splanchnic and femoral arteries, typical at arterial bifurcation. Now the come to the microorganisms. The predominant microorganism found in infective aneurysm depending on the type, etiology of aneurysm, and patient geographic location and immune system. The most common species is the Staphylococcus aureus, in which most of the methicillin resistance, and it is account for 28 to 71% of cases. Salmonella species are the most Second most common have been reported in 15 to 24%. And third one is Streptococcus species account for less than 10% of cases in post-antibiotic era. Overall, blood culture are positive in 50 to 85% of infective aneurysm patients, and organisms have been isolated from aneurysm tissue in up to 76% of patients with a suspected infective aneurysm. Gram-negative infection are more virulent than gram-positive infection, as demonstrated by rate of aneurysm erosion. 84% versus 10%, and the patient mortality 84 versus 50%. So there are some fungal infection also. They are very rare, but also reported mostly in an immunocompromised patient, with a patient with a history of systemic fungal infection. The pathogen include Candida, Cryptococcus, Aspergillus, and Pseudophila boydii. And there's a Treponema, Platinum, and Mycobacterium system also have been found in infective aneurysm. The syphilis once caused up to the 50% of infective aneurysm, but is much less common since the advent of penicillin. Finally, the tuberculosis is a rare cause and is generally secondary to erosion of TB infected periodic lymph nodes into the aortic wall. More recently, it has been reported the use of the BCG as an intravesical treatment for the superficial bladder cancer has led to the remote arterial infection involving the infrarenal aorta and popliteal artery. These are the comparison between all four which we just saw. In this, we found out that post-traumatic infective pseudoaneurysm and infective aneurysm from a cardiac source occurs in a young group, post-traumatic infective pseudoaneurysm less than 30 years, and infective aneurysm from cardiac source in 30 to 50 years. The microbial arteritis and infective from pre-existing aneurysm occurs mostly above the age of 50 years. And first two are more common. The last one from the cardiac source is very rare. And microbial arteritis commonly located in aorta, iliac arteries with intimal defects. And post-traumatic infective is mostly common is femoral and also in carotid because of trauma also. And in infection of pre-existing aneurysm is infrarenal aorta, because infrarenal aorta is a 40% aneurysm occur in infrarenal aorta. That's why it's more common in infrarenal aorta. Infective aneurysm from cardiac source usually can occur anywhere: the aorta, visceral, intracranial, peripheral. The common bacteriology is Salmonella in microbial arteritis. Post-traumatic is Staphylococcus aureus, and pre-existing aneurysm is Staphylococcus again, and infective aneurysm from cardiac source is mostly gram-positive cocci. So, how we diagnose the first is the clinical findings, what we find in a clinic, then we come to the lab investigation, then the imaging. Clinical findings is the patient presentation of an infective aneurysm will depend on the anatomical location, the virulation of the organism, and duration of the infection. The general symptoms can be because of malaise, fever with chills, although some patient can manifest in more dramatic signs of overt sepsis. Most have a non-specific clinical picture then that can be associated with back or abdominal pain, distal ambulation or pulsatile tender abdominal mass or a pulsatile peripheral mass with overlying cell lattice. Hemodynamically instability can give us a suspicion of rupture. This can be an initial clinical event. Then we come to the lab investigation. First we can have high TLC counts, leukocytosis, and elevated ESR, but non-specific finding in this infected. Positive blood culture without an obvious source in patient with a known arterial aneurysm should raise a diagnostic suspicion. Negative blood culture are not sufficient to rule out the diagnosis of an infective aneurysm. The diagnostic utility of a blood culture is limited if patient have been treated with antibiotics prior to the lab draw. Now comes to the imaging. If it is ultrasound duplex scan, it is limited to only to the peripheral aneurysms, but they have very limited diagnostic value in a aneurysm of infective aneurysm of aorta. And we can for that we can do a computed tomography angiography. CTA is the modality of choice when an infective aneurysm is suspected. Typical CTA finding includes saccular, multilobulated, or ascentic true or false aneurysm, adjacent soft tissue inflammation or fluid air within the aneurysm or in the aneurysm wall, or evidence of aneurysm rupture. Then we can combine CTA with the PET scan, which can all the infected aneurysm can show us the avid uptake of radionucleotide by the infected tissue. If the CTA is contraindicated, patient has a iodinated contrast allergy, then we can go for the MRE or MRA. Then there's a one more Indium 111 labeled white blood cells. Scanning has been used to identify prostatic graft infection, but its use has not always been accurate in infective aneurysm. Although not sensitive or specific, these study can be assistant when other imaging studies are equivocal. Now we come to management. We have two. One is antibiotics, and then is the surgical. Antibiotics. First, we start with the antibiotics. Antibiotics therapy has a critical role in the treatment of all infective aneurysm and should be initiated immediately and continue for at least 6 weeks, minimum 6 weeks, to indefinitely after surgical treatment. Pre and post operative antibiotic therapy should be broad spectrum until organism specific therapy can be instituted. Because of the importance of the organism specific therapy, obtain a set of blood culture before initiating antibiotics and obtaining tissue and fluid culture at the time of operation is paramount. The actual duration of the antibiotic therapy varies from week to lifelong and is guided by organism virulence, antibiotic sensitivity profile, as well as the arterial segment involved and type of reconstruction. At a minimum 6 weeks of intravenous antibiotics, broad spectrum antibiotics should be employed, especially in a location where recurrent infection is often lethal, such as aortic infection. Most surgeons lean towards longer, even lifelong supporting antibiotic therapy treatment. Then we have a start with a surgical management. We have some principle to tackle these infective aneurysms. First is to minimize excessive bleeding. Proximal and distal arterial control should be obtained early in the course of operation. Intraoperative culture should be obtained in all patients. Intraoperative gram stain can be useful in certain patients to assist intraoperative decision making regarding the arterial conduits and method of revascularization. Importantly, an negative intraoperative gram stain does not rule out infection. Infection control requires resection of the involved arterial segment and wide debridement of the adjacent tissue, including all the surrounding necrotic and infective tissue. Either in situ or extra anatomical reconstruction can be used. Graft conduit for in situ reconstruction include autogenous vein like saphenous and femoral, cryopreserved arterial allograft, or a prosthetic graft that is either silver impregnated or soaked in antibiotics, such as rifampicin. The type of reconstruction is used guided by multiple factors, including the surgeon's experience, patient surgical risk, and anatomical location of the aneurysm, and availability of the autogenous conduit. Falling in line reconstruction, the graft should be covered well by vascular tissue such as omentum or a muscle flap. The use of antibiotic beads placed into the infected bed or is surrounding the arterial reconstruction also been reported to be benefit. And coming to the distribution in the distribution of infective aortic, mostly it 40% is the infrarenal aorta, and the least common is the pararenal aorta. That is 4%. Then starting with the thoracic aorta, it is highly lethal with a reported mortality of 30 to 50%. Salmonella species infection does occur and is associated with a poor clinical outcome. Aneurysm formation can cause localized compressive symptoms such as dysphagia, dyspnea, hoarseness, cough, and superior vena cava compression. However, the most common presentation is rupture. Surgical excision of the infective segment, wide debridement, and long-term intravenous antibiotic remain the definitive treatment. In situ reconstruction is the most common approach, usually with a cryopreserved arterial allograft or rifampicin soaked Dacron graft. Occlusion bypass, a bypass from the ascending to the infrarenal aorta is created through a median sternotomy and laparotomy approach. More recently, treatment using endometrial stent grafts combined with antibiotic therapy has been used as an alternative to conventional thoracotomy in managing infective aneurysm of the thoracic aorta. When combined with prolonged antibiotic therapy, this may be a sexually attractive option in patients at high risk for open surgical repair. Now coming to the abdominal aorta, infection of the aorta without a pre-existing aneurysm tend to affect the posterior wall of the suprarenal supraceliac segment. Infection of a pre-existing aneurysm occur most commonly in the infrarenal location due to frequency of aneurysm in this location is more. Surgical mortality due to infective abdominal aortic aneurysm varies between 15 to 38%. Pararenal and paravisceral aortic aneurysm in situ reconstruction is preferred rather than overswing of the aortic stump coupled with aortic base bypasses to maintain visceral and renal perfusion. Currently, an inline reconstruction is preferred for most infected abdominal aortic aneurysm. Conduit options include cryopreserved arterial allografts, antibiotic-treated Dacron grafts, or creation of a new aortoiliac system. It's called NAIS with autogenous femoral popliteal vein. When an in situ reconstruction is considered not possible, then extra anatomical reconstruction in a clean tissue plane with the excision and debridement infective aneurysm surrounding tissue can be done. For all surgical reconstruction, liberal use of omental and rectal muscle flaps is important. Recently, endovascular approach has been utilized as either a bridge or definitive therapy in selected patients. Now, we have used terms so many times, cryopreserved arterial allografts. Arterial allografts for an in situ aortic resection have been shown to be quite resistant to reinfection by gram-negative organisms as well as other bacteria and microorganisms. Allografts are produced from an organ donor, processed using antimicrobial blends, and then cryopreserved using liquid nitrogen. The main limitation to the use of the arterial allograft is they are very expensive and the issue is availability. The complications associated with allograft reconstruction include perianeurysmatic hemorrhage, graft limb occlusion, and formation of pseudoaneurysm. Higher rate of graft failure and hemorrhage has been associated with aortoenteric fistulas, and this should be taken into consideration when planning repair. Then we come to the antibiotic soaked Dacron grafts. Antibiotic usually we used is rifampicin, are used for infected aneurysm with paravisceral and thoracoabdominal extension in a patient who present in extremis and require rapid surgical management for control of hemorrhage and sepsis. Antibiotic soaked graft maintain their bactericidal activity by being coated with collagen or gelatin to provide a bond between the graft and antibiotic. Rifampicin has been the agent of choice given that it has broad spectrum activity both against gram-positive and gram-negative organisms. Now we come to the neo-aortoiliac systems. Neo-aortoiliac systems we use T femoral popliteal vein to create a neo-aortoiliac conduit. The procedure has been prolonged operative time averaging around 10 hours. Because of that, it may be limited use in patients with over sepsis or elderly with a lot of comorbidities. Femoral and popliteal vein provide a reasonable good size match for the aorta in most cases and are resistant to recurrent infection. Reinfection is rare, occurring less than 2% of patients. Primary patency are 87 and 82% at 2 and 5 years respectively, along with primary assisted patency of 96%, 94 at the 2 and 5 years. The main complication of this when we are harvesting the deep veins, these popliteal, femoral and popliteal veins, there's a chronic venous insufficiency happens that lead to the reduced venous return that can lead to the edema that can lead if continues can lead to the compartment syndrome, and in some cases around 12% cases the fasciotomy is required. So then we come to the extra-anatomical abdominal aortic reconstruction. The primary extra-anatomical approach is an axillary femoral bypass in a clean operative field followed by aneurysm resection, debridement of the surrounding tissue and aortic stump closure. In stable patients, the procedure can be staged with the extra-anatomical bypass being performed first, followed by in a day or so by definitive resection of the aneurysm. The axillary artery with the highest brachial pressure should be selected for inflow. Generally, an 8 mm poly PTFA graft is sufficient. Aortic stump closure can be difficult due to limited and fragile aorta available for closure. Two-layer closure is recommended, buttressed with anterior spinal ligament and a mental pedicle when possible. We have very limited role of endovascular aortic repair in these kind of aneurysms, but it can be used when the patient is not fit for the open procedures, or it can be chosen as a initial approach, it should be considered only a bridge to a more definitive therapy in a patient who can tolerate an open reconstruction. Then we come to the femoral artery. Infective femoral artery aneurysm are most commonly due to endovascular arterial access or illicit drug injection and involve organisms that are highly resistant to conventional antibiotics. These infections present with fever, groin pain, salicitis, and pulsatile mass. Risk factors include obesity, diabetes mellitus, and groin hematoma after endovascular intervention. Staph aureus and gram-negative organisms are commonly cultured. The development of infective femoral aneurysm in the setting of illicit drug abuse is a particularly challenging problem due to presence of a highly resistant organism. These patients have a high rate of limb loss and aggressive definite treatment should be quickly undertaken. These are the four approaches. First is the most common we use the interposition vein graft we use. Then second one is the obturator bypass. The third one is the lateral femoral bypass, and the fourth one is the extranatoral axillary to distal femoral bypass. Then we come to the popliteal artery. Infective popliteal arteries are very rare. Condition usually present at a tender pulsatile mass with associated cellulitis, deep vein thrombosis from compression, lower extremity edema, and fever. Acute lower extremity ischemia may be present due to thrombosis or rupture. The most common etiology is septic ambulation from endocarditis due to streptococcus and staphylococcus species. Salmonella infection are associated with microbial arthritis and spontaneous rupture of a known aneurysm popliteal artery. The surgical treatment includes wide debridement and excision of all infective segments. In many patients, the popliteal vein is also involved, and this should be excised as well. Reconstruction with a autogenous saphenous vein bypass is preferred option performed through a median approach. Then we come to the carotid artery. The most primary carotid infective aneurysm was the result of the pharyngeal infection. With the inspection of antibiotic, carotid artery infections have become rare. Ambulation due to endocarditis is the most common cause. Again, the Staph aureus and the Streptococcus pyogenes are the most common organism. Common clinical findings include fever, chills, and pulsatile tender neck mass. The carotid mass is often medially deviated, leading to the misdiagnosis as a pharyngeal mass. Patients can also present with dysphagia due to structural compression or with a neurological deficit. If left untreated, this aneurysm can shower septic emboli to the brain or rupture because of the potential consequence of the disruption or hemorrhage after in situ reconstruction. Some authors recommend ligation and excision alone. Then we come to the most rare, the upper extremities artery aneurysms. Most infective aneurysm of the upper extremity are scanned due to the trauma or occasionally the result of emboli from the endocarditis. The use of percutaneous catheterization and dwelling catheters for diagnostic procedure and arterial monitoring can lead to the development of the infective brachial and radial artery aneurysm. A tender mass with or without salivary is usually present along with fever, chills, and leukocytosis. Ligation and excision of the infective arterial segment with debridement of surrounding tissue followed by revascularization is required if infection process involve the brachial artery. If radial or one alone is involved, ligation and debridement is generally well tolerated. Then we come to the visceral arteries. Visceral artery infected aneurysm are rare, with superior SMA being the most common site, followed by celiac artery and its branches. These infective aneurysms usually result from an embolic event due to infective endocarditis. Patient can have severe abdominal or back pain with a non-fixed tender pulsatile mass, fever, nausea, gastrointestinal, GI bleed, jaundice may also be present. Surgical treatment includes ligation and excision of the affected segment. Further revascularization is required in approximately 15% of patients and is depend on visceral, collateral flow and location of the aneurysm. An autogenous conduit, usually the GSV, is the preferred conduit. After open repair prior to closure, careful examination of bowel perfusion and viability is of utmost importance.
Hello, Bhupesh, Dr. Ashutosh here. Can you hear me?
Hi.
Yeah,
Yeah.
very nice presentation, and you have comprehensively covered everything about aneurysms.